Hello, and welcome to a recording of the 2024 Rush Parkinson's Conference, which was held on September 21st this year. However, before we jump to your video, we do want to take a moment to acknowledge our sponsors, without whom none of this would have been possible. So this includes our platinum level sponsors, Broad Street, Movement Revolution, Supernus, Amneal, and Medtronic, as well as our gold level sponsors, Abbott and Kyowa Kirin. We do also want to acknowledge our nonprofit partners, including the Parkinson's Foundation, Lewy Body Dementia Association, American Parkinson's Disease Association, and Davis Phinney Foundation. And without further ado, here is your presentation.
My job today is to give you a very short overview of where the science is going. We are about to go to the International Congress of Parkinson's Disease and Movement Disorders. It changes cities and nations each year. Actually, this year it is in the United States in Philadelphia. So we are just about this week to go for the international meeting. So I'm giving you information. Some of it will be presented at the meeting. Some of it is from last year's meeting going forward. But I want to give you sort of 5 different topics. All right. So first is treatments newly available. Then we'll go treatments that are in research, not available. Some concepts to watch for in the coming year, kind of code words and themes. And then really an issue that we face very significantly is the challenge of pursuing research programs that foster access, inclusion, and diversity, because Mark has just given you a talk about genetic forms. 10% of patients with Parkinson's disease have a genetic mutation to explain their disease. And those people are going to, in a way, they are going to have a different form, a different biochemistry potentially that may inform the rest of the population. But the distribution of these genes and the Parkinson's disease in the world, we need to make treatments that are accessible, that include all forms of Parkinson's disease, all people, and the diversity of cultures. So that's a big challenge. Many of our research programs are quite restricted to a kind of an elite, enrolled, well-informed population, but that does not mean that their genetic pool represents the entire population of genetics. So we'll mention that. And then this concept that I'm particularly vested in is trying to define our Parkinson's disease with more precision. We now define it by the clinical, and that's wonderful for clinical neurologists, but there is a biology to Parkinson's disease, and defining it and what are the ground rules of that is a great challenge for the next probably 5 to 7 years. So let's start with the first new treatments. We have drugs that are recently approved and are on the market, and that's safinamide, which is similar in some ways to rasagiline and selegiline. We have pimavanserin, that is specifically the only medicine that is FDA approved for the hallucinations of Parkinson's disease. We have istradefylline, which is used for motor fluctuations, and a new motor fluctuation treatment called opicapone, which is similar in some ways to entacapone, but it's a once a day. All right, so those are newly approved, and you could talk to your doctor if you are a person suffering with hallucinations or motor fluctuations. Those code words could be brought because those are available and the doctor can prescribe them. Now we have some new formulation of drugs, formulation of old drugs, and I think probably the most pertinent to this discussion is the new IPX product, and the brand name will be Crexont. It is approved by the FDA. It's not available yet on the shelves, but it is a combination of long-acting and short-acting levodopa, which is, you may recognize that, those of you who have been on the drug called Rytary. That's the brand name, but it's carbidopa, levodopa, but mixed, short-acting and long-acting in the same capsules. This is from the same company trying to work at sort of the new generation, the more modern, and so this is something that might be used in motor fluctuations, might be used starting medication, might be used, it just hasn't been tested outside of the study charts. But in terms of clinical practice, it is not yet available, but soon to be available, and you might want to discuss that with your doctor. There are two formulations of long-acting amantadine, one for dyskinesias, one for motor fluctuations, given at different times of the day, but you want to be aware of these and talk to your doctor. And then there are the inhalation rescue formulation of levodopa, which you inhale, so you don't have to worry about gastrointestinal issues. You don't have to worry about the kind of getting through the whole GI system, but this is taken through the lungs. But you have to be taught how to inhale, how to make it absorbed. It's not an easy drug, in my experience, to use, but something that you may find very useful in given situations. Other new things, the FDA has approved the guided ultrasound for essential tremor, but also for the tremor in Parkinson's disease. It is ablative, meaning it is destructive and different from the electrical stimulation of deep brain stimulation because a hole is burned, physically burned into the brain. And you may say, well, I don't want the tremor, so take the tremor nucleus away, but you need your brain. I mean, we just don't, willingly burn holes into it. So this is very refined. It's high tech. It is available, but it's not reversible. Once that beam goes and it is done. So once, often thinks, well, let me sort of think about other things first, but it can be very, very useful, and it is available at Rush. There are not that many machines in the country, but we do have our own. There's also interest in spinal stimulation for freezing of gait. And this would be a stimulator, not like the DBS that's used in the brain, but this would be at the spinal cord level. And you may remember in high school or college learning in biology about automatic walking of cats after they receive damage to their brainstem or to their spinal cord, and that after these lesions, the animals just walk. They just walk. They're not even on the ground, but they just walk there. There's an internal clock within the spinal cord. And if we could use that for the people who freeze, who get stuck, they just can't walk. Their shoulders go forward, they fall. Their feet won't walk. If we could mobilize that by a stimulator, we might be able to help those people that when they're freezing, the stimulator goes on and they start the automatic walking. Once they get walking, they can turn it off. But this kind of thing is very much in the interest of our patients with Parkinson's disease and freezing. All right, this work is starting. Now, what are we doing? What's in the treatment research today? Well, we have in early Parkinson's disease, unmedicated people, we are very interested in antibodies. We now know that the protein that damages the dopamine cell is secreted, bursts out after a cell dies, and then that protein infects the next cell, like a virus, like a bacterium, but it's a protein. It's a simple protein, but it damages the next cell. We need to stop that. We need to stop that synuclein from infecting the next cell. So there is a whole bevy of different antibodies being developed and tested. First treatments are by infusions. We now have a pill that we're testing, but the long term would be that we would give a vaccine. We would distill this antibody, and if you have early Parkinson's disease, the first visit would involve a vaccination, so it wouldn't get any worse. We'd still have to treat what Parkinson's the patient has, but we wouldn't allow it to get worse. That's science fiction today, but that's where the research is going. And you want to follow this. You want to follow this with intensity because we are making great progress. There are new treatments for the elements of Parkinson's disease because all elements do not progress at the same pace. And this is something that I'm interested in because I'm interested in the severity and the progression of illness. But there are new agents that are being studied. When I was a younger doctor, dopamine agonists, meaning chemicals that stimulate the dopamine proteins in the brain, synthetic products that we could make. There were two classes. There was a D1 and a D2. And the D1s were just so weak, we were not impressed with them. So the development all went into the D2s. And we have D2s. We have reptigotine, we have ropinirole, we have pramipexole. You may recognize these. They're on the market, all right? They're standard. They've been around for a long time. And we put the D1s on the shelf, and they were never studied clinically. But now there's an interest in agents that might be very mild, just to kind of perfect your Parkinson's, to make it just a little bit better, not dramatically, but a little bit better might be sufficient in early disease and in patients who are doing fairly well, but still would like to kind of titrate just a little bit more improvement. And so these D1 agonists are now being studied. There are subcutaneous infusions of levodopa trying to get a smoother effect so that you don't have to go through the gastrointestinal tract. I want you to watch these things over the year because they may come quicker than we know. There's also a liquid levodopa carbidopa. So these things you do want to watch because things usually go slowly, but then there's kind of a snowball. All of a sudden, everybody gets excited about it. The FDA approves it and it's on the market and you don't want to miss. And so keeping informed, asking your doctor, those code words of each of these that's on the slide is worth putting into your little notebook. I will also emphasize that we've come a long ways with COVID. COVID was a bad thing for us, and it's hard to come up with anything positive about that era. But one that I would offer is that we learned how to take care of patients in their homes. Telemedicine became an active way of taking care of patients, and so many patients who did not have access to us now can see us because they may be in their nursing facility. They may be at home and stranded in the wintertime because of a snowstorm, but we can still take care of them. And that technology has extended now to physical therapy, to other forms of treatment, to psychiatric care. And this is something very, very positive and makes a big difference in terms of people. And isolation is such a problem. And David will talk about this, but this has been a new way that research is really showing the improvement in patient care. There are also agents that are dealing with special problems. So for cognition, we have agents looking at cognition. For the non-motor fluctuations with the periods of anxiety that shift up and down and are horrible for the patient, we are now new treatments and areas that we're studying. Dyskinesia, the abnormal movements that come and go and mostly are afternoon and evening. And then to link with Mark's talk, there are now gene-specific therapies where we're going in and trying to manipulate the chemistry of that gene. Those patients who have the gene defect, they are eligible for those programs at the present time. But if they're successful, the chemistry of their genetic change will guide us for the patients who don't have that gene. I encourage when I first meet patients, if they're interested in knowing their genetic makeup, to get tested so we know down the road, if I get a new program for a given gene, I would like to go through my database and say, oh, I already have 20 patients who are identified and are waiting for that kind of treatment. And then we can go immediately. If we have to say, oh, well, out of all of our patients, we'll start giving a blood test and see, that's a very tedious process. And we're going to miss a lot of people. So that question of getting gene testing up front just for the possibility of having access to a program in the future is something I would have you consider. And of course, talk to your doctor. Last year, there was all this interest in vibrating gloves. And this goes back to the 19th century where it was observed that when patients went into a carriage and rode over the cobblestones of Paris, that their tremor went away, or at least significantly abated. And then it came back. But they could go out for a carriage ride and then sit down and have dinner. Or they could go out for a carriage ride and then go to the banquet and be presentable and we had no other medicines. And so this kind of idea of reprogramming the rhythms of the brain is from the 19th century. We studied this same kind of concept with a chaise longue, and there has been, at the Stanford University, there was an interest in putting gloves on, and they would vibrate and then take the gloves off, and people would be better. All this is interesting. And there's now a little ball. I don't know if you've seen it on the internet, but there's a ball, and it's like a orb, like, the queen holds the orb. You hold this ball and it vibrates. You put it down and you start to handwrite, and the handwriting is better in many patients. You can't send the ball back, so it's an investment, but it is not a major activity to purchase. It's of the $50 to $100, something like that. But there's a whole history of this, and you might want to watch this because this is programming the rhythms, the physiology of Parkinson's disease. And I'm basically, my background is chemistry, not physiology, but this is working on the physiology or the actual nerve fibers and the tracks, something to watch. Treatments that I would have you also watch are further antibodies. Dr. Hall is running programs, neuroinflammation studies. I'm working on with some dentists on oral inflammation as potentially having an impact on Parkinson's. Dr. Compoliti is interested in new treatments to slow the progression of the disease. And then, of course, the gene therapies. And Dr. Patel has been interested in that as well. New treatments for the Parkinson disease itself, slowness, walking. Dr. Afshari has worked with us on home strategies. I have kind of tried to work with new mild treatments to kind of cut the edge at the very beginning of the disease. So very, very, very mild, subtle treatments with these D1 agonists and exercise therapies, as has already been emphasized. I give you just another list. And so you see your doctor on and you say, well, there's my doctor, and that's wonderful. But cognitive studies with Dr. Fleischer, motor fluctuations, Dr. Patel, my colleague, Dr. Keshavarzian, working on the gastrointestinal. All of these could be discussed, and we're here today to discuss them. And then there's a booth in the fair that's down the hallway of sort of the various programs that are open for enrollment now. You could kind of look at them, write your name down that you would like a little bit more information on it. And that's all part of today's jamboree. So just what is research? What is it? What would be the commitment? Well, the doctors ask a clinically pertinent question, and we want to answer that question, and we're dealing with humans. In the laboratory, we can go and we control everything. We control what the animals eat, we control their exercise, we control the light, and we can then introduce whatever strategy we want to test. In the human studies, it's harder because we don't want to interfere with your quality of life, so we have to be respectful, but we also have to have a protocol. So we have to work together. Now, when I take care of my patients, my goal in that room is to make you feel better. I want to improve your quality of life. That's my job. I want to inform you. I want to be your partner. But I want you to leave feeling it was worth that appointment. That's not what a science research project is. A scientific research project has one sober goal: report accurately. If you are in a program and you're better, say it. If you are worse, say it. If you're on a placebo, your information is as valuable as the person who's on the medicine, because we're looking at the comparison, and both groups are equally important. Inevitably, the treatments will most likely have a placebo arm, but those placebo-treated patients are just as valuable. Their data, because they're the baseline, and we have to see. And most patients in studies, they get better. Even on the placebo, they get better, and that has to do with the dopamine pharmacology and the chemistry. Patients give their time, they expose themselves to an unproven treatment, but they also gain early access to agents that would otherwise not be available. They need to come to the office, they need to keep records, they need to focus on their Parkinsonism, and that may not be healthy for them. For some people, not thinking about the Parkinson's is the most therapeutic. But this audience has already told me we're not part of that group. We like to think about our Parkinson's. We need to think about our Parkinson's because that's our empowerment. And I share that with you. I share that with you. So that research candidacy includes that willingness. To be a research candidate, I say you cannot expect anything. It's an experiment. You can hope. That's your business, but we can't expect. Right? So I ask my patients, before you sign on the dotted line, do I want to get better? That's expressing hope. You should say yes to that. Do I want to help others with Parkinson's disease? That's a generosity statement, and you need to say yes to that as well. If you're no worse for saying no, but you're just not a good research candidate, because you have to contribute, because what we learn from this is going to be for all the patients. There has to be a generosity side to this. So if this resonates to you, you'd speak with your doctor, speak to the people here today, put your name on one of those lists. That's what research is. What's the challenge in terms of diversity? I show you 4 articles, and this will be a big area of discussion at the international meeting this coming week. Underrepresented population in Parkinson's disease research. It's a very, very serious problem. The people who come forward and want to know their family tree tend to be of a very uniform, homogeneous ethnicity, culture, and educational. And therefore, when we're looking and we report what's the genetics of Parkinson's, we are not able to say this is really what the world has. We don't know. So we know that ethnicity can influence recruitment in clinical trials. There's a lot of evidence on this. And we want to enhance the trial delivery. We want to expand this. Part of today's effort is to expand that. So this area is important. And my final is trying to think, and you will help with this, that we want to think about the biology of our disease. Right now, we define by tremor, rigidity, bradykinesia, and postural reflex impairment, we define Parkinson's disease. But at the beginning of the disease, a lot of diseases look like that. There's progressive supranuclear palsy. It's a completely different disease. There's multiple system atrophy, completely different disease. There's cortical basal degeneration. I could go down a list. They're much rarer, but they're there, and they all look the same at the beginning. So if we could get a blood test, a spinal fluid test, something that would give us greater specificity and sensitivity, we would be able to be much more sort of programming people's expectations from the beginning. It is always hard to say to a patient, I think we have to rethink your disease. You said, but my gosh, I've been with you for 5 years and you told me about Parkinson's disease. I said, yes, but it's evolving in a way that doesn't make me comfortable. That's hard for a patient. It's hard for a doctor, but it is the reality because we don't have a blood test that separates. We are moving in that direction, and we are now dealing with skin biopsies and various ways, spinal taps in terms of research. But follow this with us, and I think that you will be pleased with the amount of progress and how rapid it is. I'm going to stop here. I want to, again, thank you for thinking about the research, thinking about where we are today, but really projecting yourself forward, because the responsibility is we must cure this disease. We must crack it, understand it, treat and stop the disease from getting worse, but also going backwards and preventing the disease from manifesting itself. And that's where the genetics becomes so important. Thank you for your attention.